Hello, everyone. I myself, Dr. Prawin Kumar, an associate professor and head of the department Audiology at All India Institute of Speech and Hearing, Mansa Gangotri, Mysore. First of all, I would like to thank organizing team of Karnataka State Branch of Otolaryngology unit for giving me an opportunity to share with you all a topic, comprehensive audiological evaluation for common otological surgery. The content of my presentation are as follows. I will be talking about brief audiological equipments, basic and advanced used for the above purpose, which includes diagnostic dual channel audiometers, diagnostic middle ear analyzers, diagnostic autoacoustic emissions, auditory evoked potentials, and utility of these equipments in identifying external ear, middle ear, inner ear, and auditory nerve disorders. I'm sure most of you must be well versed with this particular equipment. This is a diagnostic pure tone audiometer, which help us to assess pure tone audiometry, speech audiometry, and some of the special tests to differentiate cochlear pathology and retrocochlear pathology. In addition to that, this particular equipment, which is a diagnostic middle ear analyzer, which is used for obtaining tympanometry, reflexometry, and some of the spatial tests like Eustachian tube function test, electrical SRT test, ESRT, as well as a reflex decay test. These spatial tests also again helps to differentiate cochlear pathology with retrocochlear pathology. The third equipment is very unique and special in terms of giving information about outer hair cells functioning, that is autoacoustic emission, which has the facilities of recording different types of autoacoustic emission, very quick and very rapid in giving you the information, and it gives you an idea about the functioning status of outer hair cells functioning. In advanced audiological equipment, we have auditory evoked potentials, where you can record the different evoked potentials, such as click evoked auditory brainstem response, tone burst auditory brainstem response, speech evoked auditory brainstem response, auditory late latency response, as well as some of the vestibular assessment, such as cervical vestibular evoked myogenic potential, ocular vestibular evoked myogenic potential. All these potentials you can record with single evoked potential system, provided you have these hardwares as well as softwares to operate these potentials. Let's talk about pure tone audiometry. Though it looks very simple, I'm sure most of you are familiar with these tests, because at most of the places, this is one of the basic audiological testing where clinicians obtain air conduction thresholds and bone conduction thresholds. This air conduction and bone conduction threshold help clinician to identify the quantifications of hearing loss as well as quality of the hearing loss. So quantifications means degree of hearing loss, whether it is a mild degree to severe or profound degree. Quality of hearing loss, that is type of hearing loss, you get to know through the bone conduction thresholds. As it is reflected here, you can see these four boxes A, B, C, D is reflecting you the air conduction threshold and bone conduction thresholds, which is represented with different color and different symbol. And these symbol and color is specific to ear and modalities. So the first one is representing the normal hearing sensitivity, where x-axis is having frequencies represented in kilohertz, y-axis is having intensity represented in decibel, whereas the second one is a typical example of conductive hearing loss, where bone conduction is not affected, whereas ear conduction is affected. The third one is a typical example of left ear sensory nerve hearing loss, where both bone conduction pathways as well as air conduction pathways affected, and loss is more in high frequency areas. The fourth one is representing mixed hearing loss, where both air conduction and bone conduction are affected, but the difference between the two is greater than 10 dB. So though this particular test, pure tone audiometry, where you obtain ear conduction and bone conduction threshold, looks as simple as, but gives you very informative informations, and that helps you to take a call whether patients are having hearing loss or not. The biggest drawback of this particular test is this is subjective in nature. It's a behavioral measures where patient's participation is important. If patient intentionally don't give responses, in an honest manner, you may not able to estimate these values appropriately. And that's where you have to rely on other objective measures where patient participation is minimal, and you should be able to get to know whether patient is having hearing loss or not. If patient are giving you the response honestly, then this is one of the simplest and easiest way to identify whether the individuals are having hearing loss or not. The second test, that is tympanogram, tympanometry and acoustic reflexes. This is again a graphical representation where you have x-axis is having air pressure in decapascals, extreme positive pressure, extreme negative pressure. So pressure variation is happening from extreme positive to extreme negative. And here the probe tone is used of low frequencies, that is 226 Hertz probe tone. And then y-axis is having a compliance, that is in cubic centimeter. And these different graphs help clinicians to understand whether individuals are having normal functioning of the middle ear or there is any abnormalities in the middle ear functioning. So basically tympanometry is an examination which is used to assess the condition of the middle ear as well as the mobility of the eardrum or the tympanic membrane and the conduction bones by creating a vibration of air pressure in the canal. So you get to know how the tympanic membrane mobility is. Is it hypermobile? Is it hypomobile? As well as you get to know whether the ear ossicles functioning is affected or it is intact with the help of these graphical representation. So for the convention of the clinicians, these graphical representation is given some nomenclature, which is represented as type A, AS, AD, type B, type C. So basically type A is the typical findings which is expected if middle ear functioning is normal, except in few conditions like otosclerosis, sometimes you get A-type tympanogram, though it is a pathological conditions. Similarly, if someone is having impacted earwax or someone is having perforated TM, you are expecting B-type of tympanogram. Someone who is having negative middle ear pressure, you are expecting to get C-type tympanogram. If someone is having dislocated ear ossicles, you are expecting to be hypermobile tympanic membrane, as well as dislocation of ear ossicles leads to high compliance of the middle ear. So you are expecting AD type of tympanogram. Someone whose tympanic membrane mobility is limited, it's a hypomobile, and ear ossicles movement is also restricted, you are expecting lower compliance, that is AS type, which is observed typically in otosclerosis. So very clinically, this particular test is quite sensitive and significant when it comes to clinical uses. Acoustic reflexes is again one add-on test battery in the audiological evaluations. Here, basically, clinicians try to see the integrity of the reflex arc. So there are two pathways. One is the ipsilateral pathways, another one is the contralateral pathways. In ipsilateral pathways, you are presenting the stimulus to the same ear and obtaining the responses from the same ear. Whereas in contralateral pathways, you are presenting stimulus to one ear and getting the responses from other ear. You can see here there are two cranial nerves which is involved in these reflex out pathways. One is the seventh cranial nerve, that is facial nerve. Another one is the eighth cranial nerve, that is auditory nerve. So these, if there is any breakdown in the integrity of these pathways, acoustic reflexes will be absent in that individuals, whether it is because of medullary issues or whether it is because of these cranial nerves issues. And this responses is primarily from the medullary muscles, and in humans, it's the stapedius muscles which shows a contraction because of the stimulus presented. And the presentation of a stimulus is usually loud to see the contraction, reflexes of this stapedius muscles. So usually at 65 to 70 dB, you will be able to see the contraction. So any breakdown in the pathways leads to absence of responses. Again, this particular acoustic reflex, thresholds help you to differentiate between the cochlear pathology and the retrocochlear pathology. In addition to that, if there is any disturbances in the middle ear, that also gets reflected through the acoustic reflex as well. So there is a clinical significance of this particular test when it comes to, in test battery. Autoacoustic emission, as I said earlier, helps you to assess outer hair cells functioning. Whatever values you see here, these are the signal to noise ratios, and these values help you to understand whether responses are there, whether the autoacoustic emission, the emission is robust or it is partially present. These red color symbols are the noise level, noise floor, and these are the emissions. The difference between the two is the SNR, signal to noise ratio, which is correlated with the normatives. And if a responses is present, it is presumed that outer hair cells is functioning normally. If there is any damage to the outer hair cells, leads to either partial presence of the autoacoustic emission or it leads to absent autoacoustic emissions. This particular test is very helpful in those individuals whose middle ear is not having any issues, external ear is not having issues, only the problem is lying in inner ear or above. One of the disorders, ANSDs, this particular test is very important to identify those individuals, that is auditory neuropathy spectrum disorders. Auditory brainstem response, very interesting, very important, and very useful clinically in most of the time, especially in pediatric populations or site of lesion individuals. So this ABR, which is also known as BERA, brainstem auditory evoked response audiometry. And here, basically, you are trying to see the integrity of the auditory nerve functioning. Better the synchrony, better the responses you are expecting. These responses is also dependent upon the intensities. So here again, we are trying to measure is the latency of these different peaks. These different peaks are having a different generator site. These peaks are defined by Jewett. So this is also named as Jewett peaks. The primary peaks are wave 1, wave 3, wave 5th. Wave 5th is the one which is most often looked into it when it comes to the threshold estimations. Indirectly, these ABR or BERA help you to estimate threshold. Otherwise, the typical utility of this particular test is in terms of identifying the site of lesion. That is like if there is any tumor, CP-angle tumor, or any acoustic neuroma and all, whether, what is the size and locations depending upon that response varies. For the site of lesion, the absolute latency, interpeak latencies, as well as interoral latency differences and amplitude is an important indicator. Whereas for threshold estimations, mainly clinician looked at it, presence or absence of these peaks. It also helps you to rule out individuals who are pretending to have functional hearing loss. These peaks, presence or absence, is dependent on the intensity as well. Higher the intensity level, better the responses. Okay, lower the intensity level, longer the latencies. Okay. In addition to that, in neonates, you will see that latency is prolonged. How do we define this latency? Latency is nothing. It is basically the traveling time. When you're presenting a stimulus to the external ear, to the middle ear, reaches to the inner ear, and then stimulates the auditory nerve, the time which it takes to appear this particular peak at that particular intensity level, that time is reflected as a latency. So latency is nothing. It's a traveling time. In neonates, since maturation is still taking place and system is yet to be matured, the latency is longer. For ABR, the latency, the waveform is matured somewhere around 18 months, 1.5 years of age. So this particular test is again clinically useful in most of the cases wherever you are not able to estimate the hearing abilities, hearing acuities through behavioral modalities or any other modalities. These two tests, subcortical and cortical responses, not oftenly used for the clinical purpose, especially the subcortical or brainstem responses. This is a complex ABR or speech epoch ABR, which was developed by Dr. Nina Cross in Northwestern University, USA. She used 40 milliseconds DA stimuli synthesized where there is a burst and then there is a vowel. And the responses is mimicking pretty similar to the stimulus, where you have onset responses, wave fifth and A, then you have the sustained responses, D, E, F, and then offset responses, O. The significance of this particular responses, this particular test, as well as a response that is complex ABR, is very, very important in individuals who are in the learning stage. In case of the clinical populations like learning disabilities, dyslexia, auditory processing disorders, auditory neuropathy, etc. Cortical potential is having mixed utilities, both clinically as well as for the research domain. Clinically, many a times clinicians use it for measuring the progress of the individual or how the individuals are responding to the stimulus at the cortical level. This particular test is used even in ANSD population. It is used even in hearing impaired hearing aid users, whether hearing aid is beneficial or not. It is also used for cochlear implantees to see the progress as well as in the candidacies. So basically there are 4 peaks, P1, N1, P2, N2, and this particular graphical representation help clinician to understand whether cortical potential is there or not there. Now let's have a look of, as I said, the different pathological conditions in external ear, middle ear, inner ear, and auditory nerves and above, and audiological findings. How do we go about it? External ear, the most commonly complaint of the patients are, excuse me, impact of excessive shrivelment. This is one of the common causes of conductive hearing impairment, especially in rural areas where the health icing is poor. Along with that, they do complain about pain, itching, and otitis externa. When you refer this case, the first level of interaction is, and first level of assessment is, you do, and I'm sure all surgeons do otoscopic examinations. When you're doing an otoscopic examination, you will be able to judge whether there is an impacted wax or not. If you missed out that and refer it for the audiological evaluations, we can able to identify whether hearing loss is because of impacted wax or not. If at all clinician missed out otoscopic examination report and they perform an audiological evaluations, the completely occluded ear canal causes up to 40 dB of conductive hearing loss. This hearing loss correlates well with speech audiometry, where we do a speech reception threshold and a speech identification score. So we get to know whether this conductive hearing loss is because of some pathological conditions, such as pathologies in external ear or in middle ear. Further, uh, as per test battery approach, if we do tympanometry, we will be getting B type of tympanogram if there is a impacted wax. And in the tympanogram, if you remember, I was talking about the ear canal volume. I was talking about the compliance. So there won't be any compliance in the B type tympanogram. It's a flat curve across pressure. But ear canal volume will be reduced. The reason for the reduction of the ear canal volume is because some areas in the external auditory canal is covered or taken care because of the impacted wax. So ear canal volume of that particular individual will be significantly lesser as in comparison to the normatives, of those group of individuals. I mean, pediatric or adult. The second condition, which is most oftenly seen and encountered by you all, that is tympanic membrane perforations. I will not go into detail about different types of tympanic membrane perforation, whether it is subtotal, whether it is central, or whether it is epic perforations. Irrespective of what type of perforation is, these tympanic membrane perforations leads to conductive hearing loss. And depending upon the size of the perforation, smaller the size of the perforation, lesser is the degree of hearing loss in general. However, degree of hearing loss varies between 15 dB to 60 dB of conductive hearing loss in perforated cases. It is also observed that about 60% of EO with the dry perforation goes undetected in children. Again, this degree of hearing loss correlates well with SRT and SIS when we do speech audiometry. In these cases also, when we do the tympanometry to see the status of the middle ear, most often it shows B-type tympanogram. But here, the ear canal volume will be more because of perforations. Even the middle ear cavities volume will be taken into the consideration along with the external ear cavities. And if clinician perform check acoustic reflexes, even reflexes will be absent in these cases in the affected ear. The third commonly observed patients in your day-to-day clinic will be otitis media, whether it is serous otitis media, acute otitis media, or chronic suppurative otitis media, CSOM. So otitis media is another most common bacterial infection in childhood, especially in developed countries like India. Again, here, this tympanogram, the different types of tympanogram you can see, which helps you to differentiate along with your clinical observations in the otoscopic examination and the case history, helps you to differentiate whether it is a serous otitis media or whether it is acute or whether it is chronic. Type A is mostly seen in normal. Type C is early otitis media with negative middle ear pressure. Type B is advanced otitis media with fluid. So you can see the change in the graph depending upon which stages of otitis media. In addition to that, when audiologists do pure tone audiometry, they could be able to see the different degree of hearing loss, different configuration of hearing loss, depending upon which stages of otitis media it is, whether it is serous, whether it is acute or CSO. Mild high-frequency conductive hearing loss is observed in serous otitis media. Mild low-frequency hearing loss is observed in acute otitis media, whereas CSOM most often observed higher degree of hearing loss and mixed in nature. That means even some amount of sensory neural involvement is there in CSOM because there is a long-standing, otitis media in those cases. But again, here the degree of hearing loss correlates well with speech reception threshold as well as speech identification score. When I say it correlates well, it means if there is a 50 dB PTA with the hearing loss, SRT will be somewhere plus minus 12 dB, and SIS will be proportionally good in comparison to SN hearing loss. So SIS will be good somewhere in 80%, and it correlates well with PTA. The fourth Common conditions which you will be encountering in the clinic is ossicular chain discontinuity or ossicular chain dislocation, OCD. Again, here Peotron audiometry will help you to identify whether there is a hearing loss or not and what is the nature of hearing loss. The audiogram is generally flat in configuration and airborne gap will be somewhere around 40 to 60 dB. Why there is an airborne gap? Because bone conduction is intact, but air conduction is affected. So OCD with intact tympanic membrane, it is observed higher degree of hearing loss in comparison to perforated tympanic membrane. This again correlates well with Peotron average. And most often, as I said, when you do the tympanometry, you will get higher compliance, that is AD type of tympanogram. And most often reflexes is absent because of attenuation while performing the acoustic reflex test. If at all acoustic reflex is present, it could be due to conductive recruitment. Recruitment is a phenomena where sound at the higher intensity abnormally loud and person perceive it. Otosclerosis. Otosclerosis is another middle ear conditions where audiological evaluation help you to understand the pathophysiology. Most often, it varies in terms of degree, mild to moderately severe degree conductive hearing loss. Initially, there is a drop in low frequency areas due to the stiffness in impedance, whereas if there is a complete stapes fixation, that leads to higher degree of hearing loss and maximum airborne gap. And you may see the 2 kilohertz per heart notch in Peotron audiometries. But when it comes to SRT and SRS, SIS, it correlates well with PT. When you do tympanometry, as I said earlier, it is observed the lower compliance, that is AS type, because it is hypomobile tympanic membrane or the ear ossicles. But quite often it is also observed E-type tympanogram. Mobility is not affected. In addition to that, acoustic reflex is absent in these cases. Another important audiological assessment and clinical observations you must be seeing, that is eustachian tube dysfunction. Most often you write petulous ET, that it is open most of the time. So what we do is, if tympanic membrane is intact, there is one procedure to perform ET assessment. If TM is perforated, there is another way of performing. So middle ear analysts do have an options to perform in both, check the patency of eustachian tube in both perforated TM as well as intact TM. So what happens is, when they do the Valsalva maneuver, there is change in the shift of pressure, and that shift, if there is a significant change, that helps us to understand whether ET is functioning well or not. So if minimal changes is there, that means ET is not functioning well, because ideally when you're putting a pressure, ET should open. Normally ET is closed. So when you do sneezing, when you do coughing, when you do yawning, that is the time when ET opens. So normally this particular tube is closed. So whenever you're putting an extreme pressure, should open. If it is not opening, that means that muscles is not working so well. Whereas other way around, sometimes because of dysfunction, most often it's always keeping open. So pressure is not getting built up. And what happens, there is a possibilities of, that this particular tube is linked from the middle ear to the pharynx. So there is a possibilities of infection spreading between the two. And that's most common causes of that is medius, especially in children. So that's where you have to be, having very good understanding of the physiology, and such cases should be taken care, carefully in those cases. Now it comes to the inner ear. Most commonly, you will be coming up with these meniscus cases or endolymphatic eye drops, where we say classical triad symptoms, that is vertigo, fluctuating sensory nerve hearing loss, tinnitus, and deep oral pressure. When we do Peotron audiometry in these cases, there is a possibilities of low frequency, that is hearing loss, that is rising pattern, but later on it gets shifted to high frequencies or even the flat. Most often unilaterally, it is affected, but we do see even the bilateral. So sensory hearing loss may be 1 year or in both years, and slope is again either rising or falling as well as flat. Again, there is a fair to good correlation with SHART-T and SIS. And there are some of the spatial tests in these conditions which help you to clinically understand the pathophysiology of this disease, like short increment sensitivity index, classical CC. If you ask clinician to perform, you will get to know whether Meniere's is there or not. Similarly, ABLB, that is alternate binaural loudness balance test, will help you to, clinicians to understand whether recruitment is present or absent. Other way around, adaptation tests like tone decay test that help you to understand whether it's a retrocochlear pathology or cochlear pathology. Quite often in hospital setup, they do or they ask audiologists to do glycerol test, and positive result in glycerol test gives an indication towards Meniere's disease. All these tests help you to, get a confirmation of the medical condition that is Meniere's disease. Tympanogram, most often it is A-type, and acoustic reflex may be present or absent depending upon the degree of hearing loss. And reflex decay, when it is done, it shows negative findings in Meniere's disease. Autoacoustic emission again may be partially present or absent depending upon the degree of hearing loss and configuration of hearing loss. Auditory brainstem response here do have an importance, in Meniere's disease, since it's a cochlear hearing loss, to understand which wave is present or absent and how the nature of the waves. Even the vestibular assessment is having a significance here. Usually in vestibular assessment in CVEMP and OVEMP, clinician look at it, the latencies of the peak, amplitude, interaural amplitude ratio, asymmetry ratio, as well as altered frequency tuning or not. Ideally in Meniere's disease, there is an altered frequency tuning. So these are certain parameters which clinician looked into it if they have the infrastructure to perform the test. Sudden sensory hearing loss, it's an emergency conditions where consultant has to pay attention to it, and audiologists help you to understand whether hearing loss is present or absent and what is the severity of hearing loss. Most often, if it is treated well and patient approached immediately, there is a possibility of recovery. So in sudden hearing loss, there is a possibility of flat type of hearing loss, high frequency hearing loss, low frequency hearing loss, or even the total hearing loss. And most often it is seen that it is in agreement with pure tone average in cochlear hearing loss. But in retrocochlear pathology cases, the SRT-SIS agreement is not good, it is poor. If there is losses because of CP angle tumor, acoustic neuroma, or any retrocochlear pathological conditions. Usually it is A-type tympanogram with normal static compliance, and acoustic reflexes again depends upon the site of pathology or the degree of hearing impairment. So it may be present or elevated or absent. Autoacoustic emission, most often the moment there is a hearing loss, it is absent or reduced. ABR will help you to differentiate between cochlear and retrocochlear pathology. If degree of hearing loss is higher, if it is severe to profound hearing loss, ABR is absent in those cases. Acoustic neuroma, that is again progressive unilateral high frequency sensory hearing loss is observed. And here in these cases, again, there is no agreement between SRS with the PTA, that is a speech recognition score, is not in proportion of pure tone average. And there is a possibility of rollover phenomena in these cases where there is a acoustic neuromas. And most often acoustic reflexes is absent in retrocochlear pathology cases. Autoacoustic emission is again reduced or absent depending upon the size of the tumor or location of the tumor. ABR helps you to understand how the synchrony of auditory nerve, most often it is degraded waveform, increased latency or absent waves. Absent or decrease in 77% of the acoustic neuroma cases, and latency is observed prolonged if vestibular assessment is done, that is CVIM. I was talking about ANSDs, that is auditory neuropathy spectrum disorders. This is one of the conditions where auditory nerve functioning is abnormal in presence of normal cochlear receptor hair cells. Means outer hair cells functioning is good, but auditory nerve functioning is abnormal. That is presence of OEs or cochlear microphonics, but disordered neural conduction on the other side along with auditory pathways. So when we do audiological assessment in these cases, we come up with either normal hearing or up to severe to profound hearing loss, maybe unilateral, maybe bilateral. Most often it is bilateral and symmetrical loss. And SRT and SIS don't correlate with the Orton average. Even acoustic reflexes will be absent in these cases because of dyssynchrony. However, acoustic emission is robust and present, but there is a poor morphology of ABR or it may be absent. So to sum up my presentations, this is a comprehensive table where I have listed out all the pathological conditions of external ear, middle ear, inner ear, as well as auditory nerve pathology, and the different audiological evaluations most commonly used: pure tone audiometry, tympanometry, acoustic reflexes, autoacoustic emission, and ABR. You can see that most often A stands for affected. So most often it is affected except in few conditions of cochlear hearing loss where tympanometry shows A-type tympanogram, and in ANSD, auditory neuropathy spectrum disorder, it is unaffected OEs. And type of hearing loss, you can see the first 5 conditions, it is conductive hearing loss because it is of external ear or middle ear disorders, whereas later on, inner ear or above, it is sensory nerve hearing loss. So this is a comprehensive chart which helps you to understand the different pathological conditions and possibilities of type of hearing loss and most probable findings, of commonly used audiological evaluations and advanced audiological evaluations. That's all from my side to share with you all. Once again, I would like to thank the organizing committee as well as my beloved director for permitting me to share my views, and my experiences with you all. I will be happy to, answer you any questions. If you can contact me, I shared with you my email address. I will love to hear from you all. I hope my presentation was helpful for you to, in your day-to-day clinic as well as in your practices. Thank you, one and all.